the key is to balance the guidelines and the investigations with realistic expectation. Everybody wants to do tests, but not every test add value, because ultimately, if you're spending a lot of time and money doing tests that aren't really adding value, then it can actually be working against the ultimate goal, which is doing an embryo transfer that works and getting that baby in your arms.
We've talked a lot about some of the diagnostic tests that we consider doing, but how do we treat recurrent implantation failure? What's the evidence there? Welcome to my fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Welcome back. Today, we're going to continue demystifying infertility by talking about the second part of recurrent implantation failure, which is looking into the diagnostic workup and the treatment options. In the first part of this series, in episode 72, we talked about the different causes of recurrent implantation failure. We talked about the definition, or lack of definition, I should say. So this would be a follow-up to that episode.
We're going to start with the diagnostic workup. So really, this is the question. What do we actually do when we see a patient where we suspect they may have recurrent implantation failure? When we're seeing patients where we're thinking about RIF, our approach is really stepwise. First, we're going to think about the embryos. We're going to think about what was the quality of the embryos? What was the genetics of the embryos? Like, do we know, were these genetically tested embryos? Were they not? Were they euploid? Were they not? This will give us a clue in terms of what the potential of each embryo was to succeed. We're also going to think about the types of transfer protocols that were used. Were these fresh transfers? Were they frozen transfers? Were they medicated transfers? Were they natural cycle transfers, or, a combination or a stimulated cycle? What kind of progesterone may have been given? And then what kind of those extras or add-ons have already been used?
We also review the general medical history. We look at the results of prior fertility testing. We looked at the family medical history, review things like lifestyle factors, body mass index, nutrition, and of course, loss of patient education and managing expectations as well.
Yeah, I honestly think that when I'm seeing patients for, let's say, RIF, the vast majority of the consult is really going to be about patient education. And very often, I will actually talk about the study that we talked about earlier in the first part of this series, where, does RIF even really exist? And sort of to get people to understand that this is a really controversial topic. There are no hard, fast rules or answers. And that when we talk about things, it really is this big kind of communal discussion and almost, I call it brainstorming, that we, myself and let's say the patient or patients, we're brainstorming things together, and then we're going to come up with a plan together.
When we look at testing, let's talk a bit about the Canadian Fertility and Andrology Society guidelines. So there was guidelines that we're reading on recurrent implantation failure in the year 2020. The first part, it's looking at the cavity assessment. In other words, the uterine cavity. So we're looking for polyps, fibroids, or scar tissue in the uterus that can interfere with implantation. At Markham Fertility Centre, we do a sonohistogram. A sonohistogram is a test that can be done very easily in office. It's very quick. It's normally done in the cycle between cycle day 5 and cycle day 9. And it allows to really get a good sense of what the uterine cavity looks like. Now, what is considered to be the gold standard for uterine cavity assessment is a surgical procedure called a hysteroscopy. Hysteroscopy is a little bit more invasive and it's something that, at least in most fertility clinics, it needs to be done in hospital. So therefore, a sonohystogram is considered to be an acceptable alternative in the CFA's guidelines on recurrent implantation failure for identifying any issues with the uterine cavity.
Looking at this guideline again from 2020, they also talk about parental karyotype testing as a potential diagnostic test. This is looking at the genetics of the person contributing the sperm, contributing the egg. Really, what we're looking for is translocations that could potentially lead to a higher proportion of genetically abnormal embryos. So, again, a higher proportion than we would expect just based on the age of the egg, let's say. Now, we don't do this commonly unless we're talking about recurrent implantation failure of genetically untested embryos specifically. Because when an embryo has gone through genetic testing, specifically PGT or PGTA, which we talked about in episode 30 of my fertility podcast, we are essentially already kind of screening out for parental translocations. It is worth noting that in this specific guideline, again, the CFAS guideline, the quality of evidence to do a parental karyotype was considered quote unquote low. So again, it's something that we might think about when we're talking about genetically untested embryos, but the quality of evidence to actually do it is low.
It is worth mentioning pre-implantation genetic testing here. It's a bit out of context because we're talking about a diagnostic workup. Again, what testing we do when there is recurrent implantation failure. And pre-implantation genetic testing is something that we do at the time of making embryos. So therefore, before you have recurrent implantation failure. However, I think it's worth talking about it here. In the Canadian Fertility and Andrology Society guideline, there is a direct quote that says insufficient data to recommend for or against PGTA for recurrent implantation failure. The studies are few in number and small with respect to the sample size, and there is no large randomized controlled trial data available to really recommend PGTA for recurrent implantation failure. Now, since the publication of that guideline, again in 2020, more data has come out that is supportive of the use of doing pre-implantation genetic testing and has been shown to be even more beneficial for patients where the egg provider is older than 38 years of age. Logically, it makes sense to talk about PGTA in the context of recurrent implantation failure because it is the most common reason for an embryo to fail to implant is the genetics. So if we start with genetically tested embryos, even though we know it's not a perfect test, we at least know that it's the best that we got in terms of approximating the viability of an embryo.
The guideline also talks about testing for chronic endometritis. Chronic endometritis is considered a chronic inflammation of the endometrium or the lining of the uterus. This, in and of itself, is another super messy and confusing area. And in fact, there's no consensus on the precise definition or prevalence of chronic endometritis. Basically, the doctors, scientists really can't agree on how to diagnose it or how to test for it. So then that just makes it really, really hard to study it. Therefore, the studies are super limited, and there are always lots of critiques about these studies in terms of how the testing was done, how they define chronic endometritis. In this guideline that we're referencing, again, the CFAS guideline, they say that screening for chronic endometritis should not be routinely offered in recurrent implantation failure for this specific reason.
Another test that it's worth mentioning is endometrial receptivity test. We know that there is a window of implantation when the uterus is most receptive and the embryo is most likely to stick. And I would reference episode 11 when Dr. Shan talked about this. So it would make sense that one of the potential causes of recurrent implantation failure is that the transfer is not happening in that perfect narrow window of implantation. Some companies out there have developed tests to try to assess or establish what is somebody's specific window of implantation. The evidence for the endometrial receptivity test, while it was very promising to begin with, has actually been shown to not be as helpful in most recent studies. So at this point, at best, it remains controversial in the setting of recurrent implantation failure.
Yeah, there have been some single center, multi center retrospective studies that have reported that an ERA guided, quote unquote, personalized embryo transfer may be associated with higher clinical pregnancy live birth rates in patients with previous implantation failures, especially when we're talking about euploid embryos, especially when we find that the window of implantation is actually displaced. And so we're shifting things. However, these findings are not consistently replicated in larger or more rigorously controlled studies. And really, at this point, the current evidence does not support the routine use of ERA testing in all patients with recurrent implantation failure. And its clinical utility should really be considered on a case by case basis, recognizing that there's lots of limitations and really a lack of consensus in the medical literature about this. It's worth noting that no major professional society guideline, either Canadian, European, American, currently none of them are recommending using ERA as standard practice for RIF.
Now, let's talk about thrombophilia testing. In the prior episode on recurrent implantation failure, we talked about blood clottings and thrombophilias, either inherited or acquired, has a potential cause of recurrent implantation failure. Back to the CFAS guideline, testing for inherited or acquired thrombophilias in pregnancy with recurrent implantation failure, it's not recommended. So the current evidence does not support a clear association between inherited or acquired thrombophilias and implantation failure, nor does it demonstrate any benefit from screening or treating with anticoagulant therapy in this population. As a matter of fact, there have been multiple recent analyses looking at the prevalence or the finding of common thrombophilias, like, for example, factor V or prothrombin gene mutation, or even antiphospholipid antibody in women with recurrent implantation failure, and it was found to be similar to that of the general population. Therefore, routine testing may actually increase the cost and lead to unnecessary interventions without improving reproductive outcomes at all.
So, talking now a little bit about immune testing, which again is a very, very broad term where we're talking about the immune system and the interplay that has to happen for successful implantation. In the CFAS guideline, they felt that blood work or testing of the endometrium, doing immune testing, should really be limited to research settings. There are some small studies, observational studies, where they looked at all different kinds of immune profiles, and the results were very inconsistent. And the studies are super mixed. And again, it's really about comparing like apples to oranges, right? So, immune system testing in patients with RIF is not currently standardized or universally recommended. And we will be the first people to say that the clinical utility really does remain quite controversial. Basically, it's not that this stuff doesn't work, it's just that we haven't really proven if it does work at all.
If you've been listening carefully, you will realize that the only testing that is actually recommended is assessing the uterus with the use of, for example, a sonohistogram. And I know this is disappointing, but this is because recurrent implantation failure is just so challenging. There really isn't much guidance as to what kind of testing to do. It sounds like nothing is really recommended. And even though we know as physicians that the evidence supports that, really, when you're talking to a patient in front of you who is devastated by this condition and the inability to get pregnant, it's a really hard thing to do in real life to tell the patient, sorry, there is no testing we can do. There is nothing we can do. All we can do is put another embryo in.
When we're talking about recurrent implantation failure, it really requires having a very open and honest conversation. I think reviewing all of the above. And I would like to think that I'm always transparent about the literature and the guidelines. I mean, listen, we have them for a reason, but also keeping in mind that every individual is unique and deserves personalized care. So, we're not saying that these tests do not help anyone and that these tests are quote unquote inherently bad. We just don't have enough evidence or studies to really help us make choices. And this is where that kind of shared decision making has to happen between the physician, the patient or patients to figure out where we go next and what the next steps could be.
I think the key is to balance the guidelines and the investigations with realistic expectation. Everybody wants to do tests, but not every test adds value. And as a matter of fact, it can increase the financial cost, which is a very important consideration, increase the treatments without providing any benefits, and also increase the timeline as well. Because ultimately, if you're spending a lot of time and money doing tests that aren't really adding value, then it can actually be working against your ultimate goal, which is doing an embryo transfer that works and getting that baby in your arms.
We've talked a lot about some of the diagnostic tests that we consider doing, but how do we treat recurrent implantation failure? What's the evidence there? Again, not surprisingly, this is another area of controversy, and there is no clear pathway or algorithm here. So sometimes we do end up trying empiric treatments, meaning that we're going to try some therapies really just based on clinical judgment, clinical experience. This is really the art of medicine where we might be talking about some of these things.
In the Canadian Fertility and Andrology Society, they looked at, for example, the endometrial scratch, anticoagulation medications, and immune therapy.
Endometrial scratching. This is defined as intentional damage to the lining of the uterus at endometrium, performed most commonly with a uterine biopsy pipelle or that little catheter that we use in order to improve its receptivity. It's interesting, actually, many studies have looked at this specifically, and the guideline concluded that doing this endometrial scratch or endometrial injury in the cycle preceding the embryo transfer should not be routinely offered in RIF. There's not really any evidence that it helps things.
Anticoagulation can come in the form of low dose aspirin, which is anti inflammatory and have antiplatelet properties, or it can come in the form of injectable blood thinners or low molecular weight heparin. There have been a lot of studies looking at this, and it has been shown that low molecular weight heparin modulates the expression of certain factors that are involved in endometrial receptivity and implantation. It also has been shown to decrease trophoblast apoptosis, which is the death of the cells that are going to become placenta, and promote angiogenesis, which is the development of blood vessels in the endometrium, as well as trophoblastic invasion, which refers to the placenta attaching to the endometrium and implanting.
Although this sounds promising, the studies are relatively few and the results are really inconsistent. This is also a matter of looking at studies, either looking at cells in a lab in a petri dish versus looking at an actual person taking this medication and seeing what actually happens in terms of pregnancy rates. It can sometimes be a really wide difference of things. According to this CFAS guideline, they do say that aspirin should not be routinely offered in recurrent implantation failure because there's not great evidence that it helps, and that really low molecular weight heparin should only be used in a research setting, meaning that there may be something that's promising here, but that there's not enough evidence to actually recommend it to patients in general.
That leaves us with our next topic, which is immune therapy. And there's so many. We're going to do a whole series episode on that, like we mentioned before. The CFAS guidelines mention IVIG, intralipids, steroids, granulocyte colony stimulating factors such as filgrastim or Neupogen. There's a number of studies that are looking at this in recurrent implantation failure patients, but those studies are very low in numbers and they use a small number of participants. They're very limited, and therefore the CFAS guideline comments that it is a questionable use of resources, and all of these things should only be used in a research setting and should not be part of a standard clinical practice.
To kind of summarize a bit here, the guideline basically says we may offer PGTA, we may offer parental karyotype testing. And the guideline at the conclusion also just alludes to the fact that patients with RIF really should just continue trying and continue doing more transfers, really without doing all these different testing things that we talked about, with all these different treatment options that we had talked about. And they talk about these two specific studies. And so there's published data coming from SART, which is the Society for Assisted Reproductive Technology. These are American fertility clinics who all input data into this big registry. And there was a study that was published in 2012 looking at cumulative live birth rates over 7 embryo transfers, showing a conservative live birth rate with an optimal live birth rate of between 57% and 87%. This just had to do with the statistical analyses. There was a more recent retrospective study that was published in 2019 that the guideline talks about by Coote et al. That showed a cumulative live birth rate of 49% with a median time to pregnancy of 9 months after a diagnosis of recurrent implantation failure. Really what the guideline is sort of alluding to, the guideline sort of saying is that, even in patients who are diagnosed with recurrent implantation failure or where recurrent implantation failure is suspected, that even though a lot of these diagnostic tests, a lot of these treatments aren't really recommended by the guideline, that you can consider just continuing with embryo transfers and that many people do find success.
And I think this is a really important thing to point out. And when I'm talking to patients with recurrent implantation failure, yes, I go over the immune and all the things we can do, but I also say exactly what you're saying here. Listen, the guidelines are telling me that you should just do another embryo transfer, and there is a good chance that you can achieve a pregnancy with embryo number 3, 4, 5, or whatever that is. So I understand where the guidelines are coming from. I really do. And by the same, kudos to my colleagues who have worked so hard in coming up with these guidelines and putting through many volunteer hours of reviewing studies, looking at the data. But it's amazing that they've done that. So the role of the guideline is exactly that. Let's look at the research, let's look at the evidence, and let's summarize it so that everybody's on the same page. However, it's really tough talking about guidelines when you have a patient sitting in front of you that have had recurrent implantation failure, who maybe has done 3 embryo transfer, who maybe only have 1 embryo left, who cannot afford to do another IVF cycle. And even if they could, you don't know if they're going to make more embryos. And all you can say is, well, we're going to do a sono, and maybe you already did the PGT, so that's not even valid. And if it doesn't work, then we're just going to do IVF again. But again, it's not a guarantee that you can financially, physically, and it's not a guarantee that you can make more embryos. So it's really hard to keep doing the same thing over and over again and expect a different result. Now, I think it's fair to point out that each transfer uses a different embryo. So therefore, you're not really doing the same thing over and over again. Even though you might be saying, I have transferred 3 euploid embryos, there is a difference between a day 5, 5AA euploid embryo, and a day 7, 3DC euploid embryo. So there's definitely a big factor there.
And as we've kind of alluded to, I think in the previous episode, there's still so much about the embryos that we don't know. And many physicians out there, many fertility doctors who don't necessarily believe that RIF is a separate entity will still say that it just comes down to the embryo, that it's something that we don't even know how to test for yet, right? In the more kind of granular genetics and in the epigenetics of the embryo. And there's definitely some promising research out there about recurrent implantation failure and about some of these testing and treatment options. For sure, more research is needed before we can really kind of hang our hat on anything. I agree. I think the most important thing is to have a very open and honest conversation, a solid discussion with patients so that they're fully informed and so that they appreciate that there is no magic fix that's going to guarantee that the next transfer is going to work. And that there's lots of tests and treatments out there. Some of them come with financial costs, time costs, as you mentioned, and potential actual risks to the embryo, to the person's health. And so there's really no one size fits all approach. And just because some test or something worked for your friend or worked for somebody on social media does not necessarily mean that it's going to be the thing, that magic that's going to work for you too. And in my heart, I honestly feel like it often comes down to a little bit of a lot of things coming together in the right way at the right time.
When I started practicing reproductive endocrinology and infertility, there was no PGTA. There was not the use of GnRH agonists to prevent ovarian hyperstimulation syndrome.
You're really aging yourself here, Dr. Garcia.
I know, but my point is a lot has changed in the time even I have been in practice, which is relatively speaking long, but not that long compared to
You don't look a day over 25.
Oh, that's because you love me so much. You're blind. But I am hoping that over the next 15 years, before I retire, at least, we want to see some development in recurrent implantation failure. So some of the things that are coming down the pipe that I hope I'm going to make a difference would be, for example, advanced tool in embryo selection using artificial intelligence. With artificial intelligence, we might be able to get a better understanding of the endometrium, a better understanding of embryo selection, a better understanding of a more refined immune profiling, and hopefully a better biomarker for receptivity. Maybe I have too much faith in artificial intelligence, but I'm certainly hoping that we can use it to improve outcomes in fertility and help patients with recurrent implantation failure.
And some of this stuff is on the horizon. It's not still like Star Trek where it's so many years away. Even at a recent CFAS meeting, there was somebody who was presenting on whole genome sequencing. So instead of just looking at the chromosomes of the embryo, you're looking at the specific, every single gene of the embryo and looking at these big studies of the embryo to, again, help us better predict which embryos and which euploid embryos are capable of succeeding and which ones aren't. That even an embryo that is euploid may fail because of X, Y, Z, and being able to predict and help us to better select for embryos and have a much better idea or a clearer sense of the chance of success with a specific euploid embryo too. So that's also definitely coming down the pipeline.
What we want to leave you with after this episode is recurrent implantation failure is complex, it's frustrating, it's emotionally taxing for both patients or clinician. But with each case, we'll learn a little bit more, and there is ongoing research. So we hope that there is improved fertility outcomes for patients with recurrent implantation failure in the future.
If you've listened to these whole series of episodes and you feel like you're walked away more confused maybe than when you started, I can totally understand why, and I can totally appreciate that. But I think at the end of the day, it's all about having that discussion with your fertility physician if this is something that you are experiencing, and really kind of talking it out and figuring out what your next steps could be. And again, the immune podcasts are coming as well, and we're going to be delving into that in deeper detail. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramir C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.